afternoon, everyone, and thank you for joining today's webinar with Cancer Support Community Los Angeles. My name is Kathy Riley, and I'm the Associate Director of Programs at CSCLA. And I am honored to welcome you to this week's webinar titled Radiation Therapy for Breast Cancer, a Historical Perspective and New Approaches. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. And before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not get to all your questions today, but we'll try to get to as many as possible. Dr. David Kahn is a board-certified radiation oncologist and assistant clinical professor at UCLA. He is the medical director at the 21st Century Oncology California practice in El Segundo. His interests include intensity modulated radiotherapy, stereotactic body radiotherapy, stereotactic radiosurgery, and high-dose brachytherapy for breast malignancies. Dr. Kahn received his medical degree from Oregon Health Sciences University and was the recipient of the post-sophomore fellowship in anatomic pathology. He then completed his internship and residency at New York University. In addition to his busy clinical practice, Dr. Kahn has extensive clinical research and has numerous publications on cancer care disparity, prostate cancer, and breast cancer. And in recognition of his superior clinical acumen and compassionate bedside manner, Dr. Kahn has been selected as one of the best doctors in America since 2008. It gives me the greatest pleasure to introduce Dr. David Kahn. Dr. Kahn, go ahead and turn your video on and join us.
Okay, so thank you very much for that very nice introduction. I think you can see my screen now. Kathy, can you just nod your head if you're seeing the slide? Okay, so I'm going to apologize in advance. I may be interrupted for about 5 minutes during the talk, so I'm sorry for that interruption. I'm the medical director for the UCLA Radiation Oncology Network, which includes El Segundo, Los Alamitos, Northridge Hospital, and California Hospital. And I think before we can actually understand what we do for breast cancer now, we need to understand how we got there. And cancer is one of the oldest diseases to afflict humans. We know from mummified skeletal remains in Egypt as well as in Europe that there were human beings with cancers invading into the bone. So we know it's one of the oldest diseases known to humankind. Imhotep was a physician or a scholar. It's not really known much about him, except for that he was a person of prominence in Egyptian times. And he first described a breast tumor in 2500 BC on ancient papyrus. And what he described was a bulging tumor within the breast, which was extremely hard and felt like a ball of wrappings. And the treatment for this disease was something that they called a fire drill. And this is probably the earliest documentation of breast cancer. In the Greek times, cancer was known as karkinos, and it was primarily a descriptive term because the ancient Greeks noted that this disease had a hard shell, much like a crab, and it had finger-like projections like the legs of the crab, and these projections would invade into other tissues, into other organs, and often it would be painful, much like the pinch of a crab. And from that, we also have the term oncology, which is the Greek term for swelling. Not much was known about cancers, how they originated or how they progressed. And since human beings did not have the understanding of what caused the cancer, the treatments were stagnant. And it was initially thought that this was due to an imbalance of four humors. And because it was an imbalance of some form of liquid within the body, it wasn't felt that surgery was going to be an adequate treatment. And this feeling that it was a humoral imbalance persisted until the 17 and 1800s. It wasn't until the anatomists Vesalius and Bailey started to look for this humoral imbalance that we knew that this was incorrect. And these were anatomists who dissected human corpses between 1500 and the 1800s, and they were searching for a tumor that was filled with black bile. And when they failed to identify this black bile, which was thought to be the cause of cancers, they realized that hypothesis was incorrect. Virchow was a pathologist, and he's considered to be the father of modern pathology. He examines tissue underneath the microscope, and he identified individual cells which were specific to different parts of the body. And it was his belief that it was the reproduction of these cells which resulted in a tumor. Theodore Boveri was interested in Mendelian genetics, and he was the first person to actually postulate that cells arose from a single abnormal cell, and that these cells would reproduce unchecked and result would result into a tumor. So with this new knowledge, it became clear that the hallmarks of cancer were uncontrolled cellular proliferation, the lack of a programmed cellular death, unlimited cell divisions, which is often called immortality, and the ability of these cells to draw on a blood supply, because these rapidly dividing cells needed nourishment to sustain their growth. And the last hallmark of cancer is the ability to invade into local tissue and result in metastases. And the analogy that I like to use with my patients is it's like an oak tree. An oak tree has roots that grow into the soil, and it'll invade into other parts of your garden, and it'll drop these acorns. The acorns can then be taken to other areas of the garden by chipmunks or other animals, and those acorns can grow and develop into oak trees on their own. And that's really what a cancer is the ability of cells to take root, invade and destroy tissue, and then drop seedlings which can grow in other parts of the body. So knowing that it was not due to an imbalance of humors, there was the idea that surgery may be able to cure patients of cancer, but we as physicians had limited understanding of what caused an infection. And it wasn't until 1859 when Pasteur postulated that tiny microorganisms that were too small to be seen with the naked eye were the result of, or were the cause of infections. And through a series of clever experiments, he demonstrated that it was not air that caused infections, but bacteria. Just because we could remove something, we didn't have the tools to adequately anesthetize patients. And it wasn't until ether was discovered as an anesthetic that we were able to dissociate pain from physical trauma. So knowing what we knew about anatomy, the cause of cancer, asepsis and anesthesia, this led to the rise of the surgeon. And Halsted was a famous surgeon that practiced in the 1890s, and he pioneered what was called the radical mastectomy. And what you can see here is he believed that if you remove the breast entirely en bloc and remove the next step of where cancer would spread, which was the lymph nodes, you would be able to cure the patient of cancer. And so his idea was to get normal tissue around the breast. You can see the tumor here, remove the entire breast in a single specimen, and then remove all the lymph nodes, which was thought to be the next site of spread for cancers, that these patients could be cured of cancer. And as you can imagine, this was a very deforming procedure. The dissection was taken all the way down to the chest wall and the bone. And it's really, even now, it's shocking to me that this type of surgery could have been done back in the late 1800s. Concurrent to this, Röntgen discovered something which he called an X-ray. Working with cathode ray tubes, he noticed that an invisible ray would be emitted from the cathode ray, or from the cathode tube, and photosensitive paper would be able to capture images. And this is one of the earliest radiographs of Röntgen, and you can see a picture of his the bones in his hand with his ring. Meanwhile, in France, Marie Curie discovered radium, which had similar properties to these strange X-rays discovered by Röntgen. And Marie Curie actually won the Nobel Prize in physics for her work. And shortly after her discovery, radium was actually used to treat basal cell carcinoma, which was one of the earliest uses for radiation to treat malignancies. Shortly after that discovery, radiation was used for breast cancer. And this patient was a patient that was seen by a dermatologist in 1900. She'd undergone a radical mastectomy, and shortly after her procedure, she developed these nodules within the chest wall. And so Hussey, the dermatologist, actually applied radium directly to the tumor, and he was able to cause the tumor to shrink. And you can see that approximately 3 months later, the tumor had been essentially eradicated. Shortly after that, Keynes in London sort of mimicked what was being done with the radical mastectomy. And what you see is he used radium tubes inserted into the breast to treat a breast tumor. He also put these radium tubes into the axilla, which would essentially be the lymph node dissection that Halsted did, and put in radium tubes in the supraclavicular fossa as well as into the internal mammary area. And so, although he had very good results with this technique, his work was largely ignored, and patients and the radical mastectomy still was considered to be the gold treatment standard. And I should note that up until 1950, there were major limitations to using radiation therapy as a treatment modality. The first was radium was extremely rare. And so physicians and patients did not have access to radium. The radiation therapy units were very crude at the time. And because of their inability to penetrate deeply into tissue, its utility to treat malignancies deep inside the body were fairly limited. During World War II, nuclear reactors were created, and cobalt-60, a radioactive isotope, was developed, and this was used for initial radiation therapy units. But it wasn't really until the development of the linear accelerator that radiation therapy could be used for the majority of patients. The Varian brothers in 1947 developed what they called the linear accelerator, and it was a machine that was able to create very high energy penetrating X-rays that would be able to go into the deep parts of the body. And Kaplan at Stanford in 1953 used this device to actually to treat patients. The Varian brothers developed the machine. Kaplan he sort of applied it to patient use, and this is one of the very first patients that was treated at Stanford University Hospital in 1953. And so now there was an idea that there was another option for patients that could treat the breast cancer that would be less deforming than the radical mastectomy. And so Bernard Fisher at the NCI challenged this belief. And I will note that the initial studies were primarily patient-driven, meaning patients essentially refused to undergo a radical mastectomy. They asked to see if there was something else that could be done. And because of this, Bernie Fisher wrote NSABP B06. B06 was a landmark study, and what it did was it compared three separate treatment modalities for the treatment of breast cancer. And it was a randomized study, which is considered to be the purest way to perform a study. And patients who enrolled into NSABP B06 were randomly assigned to either receive a mastectomy, lumpectomy, or lumpectomy with radiation. And this is a very important question, because one of the most common questions that patients will ask me is, my surgeon removed the tumor, they got normal tissue around it, why would I even need radiation? And so this initial study really served to address that question, as well as, is lumpectomy and radiation therapy, is it adequate for breast cancer? And so a couple important findings were generated from the study. The first is, if you undergo a lumpectomy only, and if you get normal tissue around it, the chances of something recurring within the breast approach 40%. If you have radiation therapy afterwards, you can lower that to approximately 12%, 11%. And so this showed that lumpectomy only was inadequate. It also showed that lumpectomy and radiation had equivalent results to mastectomy. And so after this study had been conducted, radiation therapy, lumpectomy with radiation therapy became a viable option for patients wishing to save their breasts. Anytime we see patients, we will stage them I don't want to spend too much time on the staging aspect of breast cancer, but just keep in mind that there's a T stage, which indicates the size of the tumor, and also whether or not the lymph nodes are involved. And this will often determine how much tissue we need to radiate. And I'll also point out this ductal carcinoma in situ. Ductal carcinoma in situ, going back to the oak tree analogy, ductal carcinoma in situ is philosophically can be thought of as that, like a field of acorns, that if you were to leave them in the soil, they would eventually grow into an oak tree and in a cancer. And this is important because historically, ductal carcinoma in situ has been treated almost identically to invasive ductal carcinoma. So, which is why it's in the staging manual to begin with. Many times patients will ask me, you know, I don't even have a true cancer. Why do I need to have radiation? And again, there's been a preponderance of studies that have identified the need for radiation therapy in the treatment of ductal carcinoma in situ. So how does radiation therapy work? Radiation can be thought of as a massless, invisible ray that has energy, and when the X-rays hit the cell, it causes an ionization, and the ionization will the ion that's created will attach itself to the DNA and cause damage to the DNA. And if you recall to your high school and college chemistry, DNA is the backbone of all the cells, and so it's what they call a double helix. A double helix is if you were to take a lateral or a ladder and twist it, you would have this sort of twisted material, and this is the genetic blueprint of all cells. And one strand of the cell is a mirror of the other. So when radiation is employed, it causes one of these strands of the DNA to be damaged. The normal cells are able to repair themselves using the other strand of the other half of the DNA strand as a template. Malignant cells are unable to repair themselves, and when the cell tries to divide, it'll die. And so that really served as part of the basis of what we call fractionation, meaning we deliver a little bit of radiation every day for a certain period of time. In between each radiation dose, the normal cells are able to repair the damage, but malignant cells are damaged, and when they attempt to divide, they end up dying. Contraindications to breast conservation therapy, any prior radiation therapy. Excuse me one second. Having a problem. Oh, okay. Let me. Hello, sorry. That wasn't quite the interruption. Okay. If the tumor is too large and the breast cannot, if there's an inadequate amount of breast tissue after a lumpectomy, we normally will recommend a mastectomy. And if there's a BRCA mutation or a genetic mutation that predisposes the patient to development of breast cancers, we also discourage radiation therapy. This is a picture of a modern linear accelerator. and typically when we treat patients for breast cancer, the beams are going tangentially. So what we're seeing here on the right-hand side is a cross-section of a patient's body. This is the patient's right side. Oops. This is the patient's left side. This is the patient's breast here, and the beams are coming this way and this way. So the beams are essentially skimming the patient's body. The radiation therapy process is this. We perform something called a simulation. The simulation will include production of a device to position the patient in the same position every day. Then we'll perform a CT scan to generate a computerized plan that'll tell us how much radiation to give during each session. And the radiation therapy is usually given Monday through Friday, 5 days a week for a period of in between 5 and 30 treatments. So this is the immobilization device I'm talking about. This is a what they call a vac lock. This will conform to the patient's body. The patient's arms are usually above their head. The radiation beams would be coming this way, tangentially across the patient's body. Sometimes during the simulation, we'll mark out the area of clinical interest to help us with planning purposes. And after we perform the simulation, we'll perform a CT scan. So this is a CT scan, and we're looking at it in 3 different planes. This is what they call the axial plane here. And in this plane, the patient's head would be sort of away from us, and the patient's legs would be sticking out towards us. This is a frontal view, which they call a coronal view, and this is a side view. And we can look at the area of interest in any different plane. And I know it's hard to see on this particular panel, but I've already contoured the breast and where the lymph nodes are here, and we can see a color-coded map over here. And here's a enlarged view of that, and what you see are the lymph nodes contoured, as well as the breast tissue and the lung. In the coronal plane, we can see the lymph nodes, level 1, 2, and 3, and the lung. The breast is not seen on this image. Once we finish the contours, we can generate a computerized plan. The computerized plan allows us to see how the radiation dose is being distributed. And what you're seeing here is it's almost like a weather map. The areas that are red are where the majority of the radiation therapy is being delivered. Where it's blue or green or yellow, it's lesser amounts of radiation. And we can calculate the amount of radiation that's being received by every structure that's been contoured, the lymph nodes, the breast, as well as areas that we want to avoid, such as the lung. So this is what we call a dose volume histogram, and our targets are on the right-hand side. And ideally, what we'd like to see is high doses of radiation being received by the target here. And on this side, this is the scale on this is the amount of radiation. So we want normal structures to get as little radiation as possible. So we want to see high doses of radiation towards the target, lower doses of radiation to normal structures. This is the lung. In this patient's situation, it was unavoidable. So again, receiving much less radiation therapy than the targets, but more than some of the other structures. And this is really how we evaluate whether or not a plan is suitable for the patient or not. Once we finish the treatment plan, we move forward to the actual treatment. And once we position the patient, it's very important to confirm that the position is exactly how it was during the actual simulation. And so the linear accelerator actually has imaging on the machine. These wings will come out of the machine, and we can take pictures of the patient, either a CT scan or regular X-rays. And what you're seeing here is this is a checkerboard where on one in half of the quadrants you're seeing the pictures that were taken at time of stimulation, and then during the actual treatment we're making sure that things align correctly. These are the contours of the breast that were generated on the CT scan. And so we can confirm that on this patient, the alignment was perfect. Once the alignment's been confirmed, we deliver the treatment. Another way to target the radiation correctly is to use optical surface guidance. And what you see here is there's infrared cameras positioned in various parts of the room that allow us to monitor the surface anatomy of the patient. This is a very accurate and precise way to delineate the target. This one advantage of this over the image guidance is this allows real-time imaging of the patient. The image guidance, the orthogonal film, this is like a picture. You don't know what happened before or after the picture was taken. With this optical surface guidance, since it's not using X-rays, we're actually seeing real-time information, so we can see if the patient is coughing during the treatment. We can see if the patient is fidgeting or moving. And if the patient is moving out of the treatment position, the treatment can be interrupted. So now I want to sort of shift gears and talk about ways to avoid normal structures that don't need radiation. So, you know, as most of us know, as we know, the heart is on the left side of the patient. And again, this is a, oops. Excuse me 1 second. This is a cross-sectional image of the patient's breast. And again, this is the patient's right on this side. This is the patient's left. And this is the target, the breast. And the beams will be coming this way. What we're seeing here is the heart. And the heart is partially within the treatment field. So in order to avoid the heart, we can ask the patient to take a deep breath. And what happens is the lungs will expand with air, and it'll physically push the heart out of the treatment field. And so this is one of the techniques that we can employ to avoid radiation therapy to the heart. And you can see again, here's a nice dosimetric picture of where the radiation dose is being delivered, and you can see that the heart is being avoided in this. Just a sort of a cartoon image of what's going on. Another way is to treat the patient in the prone position. Prone is with the patient face down. And again, you can see here's the patient's left breast. And if the patient was treated in the supine position with the i.e. face up, the heart is really just underneath the chest wall. So to avoid that, we can place the patient into the prone position, face down. The right breast is supported, and the left breast sort of falls through this aperture. And what you see is the breast is falling down, and so now we can actually treat the patient while avoiding the heart. We can use fancy beam shaping techniques to minimize radiation to the heart, called IMRT, which is, again, another way to avoid treatment, but treatment to the heart. But I think most of the time, either the prone position or the deep inspiratory breath hold works the best. In terms of treatment delivery, the historical standard had been Monday through Friday, 5 days a week for 6 weeks. Now there's newer data that states that maybe we don't need to treat the whole breast. Maybe we can deliver higher doses of radiation just to the tumor bed. And so a study that was performed in Milan actually compared whole breast radiation therapy to accelerated partial breast irradiation, where we are just treating the tumor bed with a margin. And again, this was a randomized study. And what they found was that in terms of cancer control and local recurrence, whole breast radiation therapy was equivalent to accelerated partial breast irradiation. And the advantage of this is, instead of doing 6 weeks of treatment or even 4 weeks of treatment, they were able to compress the treatments into 5 treatments given daily for 5 treatments. So this is extremely convenient for the patient. And again, you can look at the treatment plan here. This, what I've contoured here, is where the tumor bed had been, and you can see that we have a nice orange isodose distribution right around the tumor bed. There's also been studies looking at radiating the entire breast in 5 treatments. This is a slightly lower dose. And again, these results are equivalent to the whole breast radiation when given over approximately 15 treatments. So here is the historical standard, 30 to 35 treatments. There's more and more data that show that 20 treatments are just as good as 30 to 35. And for select cases, 5 to 10 treatments are equivalent to the 20 treatments. So sort of going through the history of radiation therapy, we went from having a very poor understanding of breast cancer, its pathophysiology, and how to treat it. In ancient times, it was treated with the fire drill. And now that evolved into removal of the entire breast via the radical mastectomy. Oh, did she get treated already? Can we treat her and then I'll see her afterwards? Oops. I'm sorry, the radical mastectomy, and then the age of breast conservation therapy, where radiation therapy was combined with a smaller surgery to achieve equivalent results and save the patient's breast. So radiation therapy is an effective treatment for breast cancer, and it allows women to avoid deforming surgeries while maintaining excellent treatment outcomes and cosmetic outcomes. Modern beam shaping and alignment techniques allow us to maximize radiation therapy to the target while minimizing unnecessary radiation to normal tissue. And the use of hypofractionation, pure treatments, has improved the convenience for patients and allow us to deliver treatments while maintaining the safety and improving convenience. And that's the conclusion of my talk.
Well, Dr. Khan, thank you so much for that really wonderful talk, and the information and the explanations. I know I learned a great deal. So thank you for that. And we have received some questions in the Q&A feature. So I don't know if you see those, or you want me to.
I'm looking at them, and so is stereotactic radiotherapy available for chest wall and axillary region? And the answer for that is no, not at this time. Stereotactic radiotherapy, if I understand the question, is delivering very high doses of radiation. Well, SBRT has specific definitions, and it usually involves delivering high doses. So I think that's what this person is asking. So stereotactic radiotherapy is typically not used for the treatment of breast cancer and the regional lymph nodes, simply because a large nerve goes through the axilla called the brachial plexus, and we don't believe that it's safe to deliver that type of dose to the axillary lymph nodes. So no, it's not used. Previously, we believed that if you had lymph node involvement, we would treat the regional lymph nodes, and that the safest way was to go back to sort of the old treatments, the conventional fractionation over approximately 6 weeks. Now there's more and more data to say that we can use this hypofractionations, or the shorter treatments. So now I think the United States is going to treating the regional lymph nodes in 20 treatments, but probably not any fewer than 20. I don't think that would be safe. Is there any, I am not familiar with Taylor-RT trail. Is there any data yet from the Taylor-RT trail? So I don't have any answer for that. I am learning. Okay, the question is, I am interested in learning precisely, is it calculated how many radio sessions and for how long in a specific case? And so that really kind of goes towards staging. We also look at anatomy. So philosophically, if the lymph nodes are involved, then we believe that not only does the breast need to be treated, but the lymph nodes. And so typically that will be anywhere between 4 and 6 weeks. And again, I think the American standard has been 6 weeks, but we are going towards the hypofractionation. So it may be as few as 20 treatments. In terms of whether or not some of these other techniques can be used, the accelerated partial breast irradiation, fast forward, that often is based on anatomy, where the tumor bed's located, whether or not we can localize that adequately, how large the patient is. Larger patients, we have difficulty in planning. So that's why it's great to have options that can make it kind of confusing for the patient. But that's sort of the thought process behind how many treatments. Typically, the radiation oncologist will sort of rely on published data, but the technique may be different. I don't know if that answers the question or not.
I'm also seeing a question here that we received at registration, and someone is asking if you have already had radiation therapy and you have a recurrence, can you do radiation therapy again?
You can, but it's discouraged, and because when we give radiation, we normally give as much as we think is safe to allow normal tissues to recover. So the traditional recommendation is to do a mastectomy. In some extenuating circumstances, we may consider radiation to a smaller volume. We may use that that partial breast irradiation technique. But again, we normally counsel the patient that that's not the preferred treatment option.
And then someone else is asking, does short-term radiation treatment offer a better quality of life compared to chemotherapy? And are the outcomes from the two modalities comparable? There's a lot in there.
Yeah, no. So I first address the chemo versus radiation question, and the analogy that I use is, if you buy a car and you've decided between a Nissan and a Toyota and a red or white car, those two decisions don't necessarily affect the other decision. And the question for chemotherapy is, chemotherapy is a medication that goes through the veins or is taken as an oral pill, and it treats the whole body. And radiation is what they call a local treatment. We're just treating either the breast or the breast and the lymph nodes. And so many times we will use both together, or we'll use either both together. But the question for radiation is really more of a mastectomy versus lumpectomy and radiation option. Lumpectomy and radiation philosophically are considered to be equivalent to mastectomy. So there's many situations where a patient will have mastectomy and chemo, or a patient will just have mastectomy and no chemo, or lumpectomy and radiation. The treatments don't really overlap. We sort of determine what's the systemic risk, and that's where chemo comes into play, and what's the local risk, and that's really mastectomy versus radiation and lumpectomy. In terms of quality of life, you know, I'm a radiation oncologist, so I think that the side effects of radiation are less than chemo, but it certainly depends on the type of chemo. There's, you know, it'd be too hard to say. I think the side effects of radiation are just kind of local to the area that we treat, which is typically just the breast or the chest wall.
And then a question that came in at registration that I think has to do with side effects is a nice follow-up to what you just said, is, are there long-term effects of radiation on the body or on the immune system?
Well, so the short-term side effects are going to be a skin reaction, some redness of the skin, maybe itchy, some fatigue. Those are all side effects that almost everybody has to some degree. The whole idea of fractionation was to sort of minimize long-term side effects. That's why we give a little bit each day. And as our ability to shape the beam improved, that allowed us to give higher doses of radiation with greater precision to a smaller area. When we're treating, you know, the breast is an organ that sort of sticks out of the body, so it's relatively easy to treat in the sense that we don't have to go through too many other organs to actually treat it. Even if we treat the lymph nodes, we're not treating the same volume of normal tissue as we would if we were treating the stomach. Okay, so long-term side effects are usually minimal. We're concerned about radiation to the heart, of course, but there can also be a little bit of shrinkage of the breast. I think anytime a patient gets breast cancer treatment, there's going to be some shrinkage because normal tissue is being removed in addition to the malignant growth, and the radiation itself can cause a little bit of scarring or shrinkage of the tissue as well. So those would be the main things to be concerned about.
And then another question that's come in during the webinar, are radiation therapy side effects, risks to the heart higher if treatment is on the left breast?
I think with modern techniques, we can essentially avoid any sort of significant long-term sequela to the heart.
Wonderful. And then
I'm still here. Okay.
And we want to be, yes, we want to be sensitive to your schedule, and so we can finish up. Or do you have time for one more question?
Well, I think one more question.
Great. So a final question that's come in during the webinar is there a danger in days of interruption? Someone is saying,
well,
yeah.
If it's 1 or 2 days, I can definitely say there's no concern. All right, and so we know that because it's community standard not to treat during Thanksgiving, Christmas, and New Year. So we know if you miss one treatment here or there, it's going to be fine. But what we want to avoid is someone taking a vacation in the middle of the treatment. So we try to get the radiation completed before or after. So and the longer that gap is, the less effective the radiation is going to be. So I don't know if that answers the question for the person who was asking. If it's an isolated event, or even if it's a couple treatments, we don't consider it to be an issue. It's really sort of extended, like missing a whole week of treatment or 2 weeks in a row, or only coming in 3 days a week or 2 days a week. So that's when we consider it to be an issue.
Well, we have reached the end of our time together, and Dr. Khan, we want to thank you for sharing your time with us today and sharing your expertise and engaging with us and answering all of those questions. And I want to thank our participants too for your engagement and for joining us today. If you would like to learn more about the cancer support community, you can visit our website at cancersupportla.org. And then I have added Dr. Khan's UCLA profile to the chat as well. So if you'd like to learn more about him and his work, you can do that as well. And then you can always email us at info@cancersupportla.org for any other questions. And thank you for your attendance today. Thank you, Dr. Khan, and we'll see everyone at our next educational webinar. Goodbye.
Okay, bye.